Okay, Senator, sorry about that.
All right, no worries. Good morning. I'm Jeb Bradley, Senate District 3. Today we are holding a meeting of the Senate HHS Committee. Before we get started, I'll read through a checklist to ensure the meeting that we are holding is in compliance with the right to know law. As chair of the Senate HHS Committee, I find that due to the state of emergency declared by the governor as a result of COVID-19 pandemic and in accordance with the Governor's Emergency Order 12 pursuant to Executive Order 2020-04 and its extension, this public body is authorized to meet electronically. Please note there is no physical location to observe and listen contemporaneously to this meeting, which was authorized pursuant to the Governor's emergency order. In accordance with the emergency order, I am confirming that 1, we are providing public access to the meeting by telephone with additional access possible by video and other electronic means. We're utilizing Zoom for this electronic meeting. All members of the committee and selected legislative staff shall have the ability, to communicate contemporaneously in this meeting through this platform, and the public has access to contemporaneously watch and or listen to the meeting on Zoom or YouTube and via phone by following the directions and links provided on the General Court website. We have provided public notice of the necessary information for accessing the meeting in the Senate calendar. Number 3, we are providing a mechanism for the public to alert the public body during the meeting if there are problems with access. If anyone has a problem, please email remotesenate@leg.state.nh.us, or you may call 603-271-6931. In the event the public is unable to access the meeting, it will be adjourned and rescheduled. Please note all votes taken during this meeting shall be done by roll call vote. Finally, let's start the meeting by taking a roll call attendance. When each member states their presence, please also state where they are and if anyone else is in the room with you during this meeting, which is required under the right to know law. I will call the roll. Senator Gray.
I am James Gray. I'm in my office in Concord, and there's no one else in the room.
Senator Avard is unavailable today. Senator Sherman.
Senator Tom Sherman, I am actually driving with my video off, thankfully, and I'm alone.
And Senator Whitley.
Good morning. This is Senator Becky Whitley. I'm at my home in Hopkinton, and my alone in the room, but my husband is in the house.
And I'm Jeb Bradley, and I am in the 3rd floor Senate offices. Okay, so the hearing is about the amendment that I was asked to introduce by the Department of Health and Human Services concerning the recent Supreme Court order. Let me just say that obviously this is a very late hearing. It's going to require 2/3 to pass it in the Senate. And that's probably a good thing given how late it is. So I won't say anything more about it because it was the department's amendment, and I would like Griffin and Kirsten, if you could bring in Commissioner Shibonet, Melissa St. Cyr, and Dr. Ballard.
Melissa St. Cyr, Commissioner Shibonet, and Dr. Ballard should be in.
Good morning, folks.
Good morning. Is it okay to go ahead and start?
Go ahead. Yep, go ahead.
Great, thank you. So this is Lori Shibodet. I'm in Brown Building. I am alone in my office. Thank you. I want to give you a brief synopsis of this proposed legislation, and then I'll ask Dr. Jonathan Ballard to provide a perspective from a physician's point of view. Melissa and myself and Jonathan should be on to answer questions for the remaining of the hearing. What I first want to describe to you is what an IEA feels like. An IEA, which is an involuntary emergency admission, means that the patient has the inability to choose an alternative site of care, means their freedom has been lost, They have loss of access to belongings, their phone often their family. In many cases, they're placed in a windowless room. And we all agree that the patients that need an involuntary emergency admission needs this level of security and should be transferred to a DRF as soon as possible. This legislative change targets patients that should not be IEA'd. For several years, I have heard from several ER providers who stated that they had no other way to hold a patient other than an IEA. A Hampshire hospital started deferring patients that did not meet IEA criteria. This included patients under the influence of drugs and alcohol, elderly patients with dementia, patients that presented voluntarily and wanted a voluntary stay, and homeless patients. We are not saying that these patients do not need care, but they certainly do not need an involuntary emergency admission. 2 to 3 years ago, when we started to address these issues, 40% of all IEAs were rescinded prior to a transfer to a DRF. A local media outlet just reported last week that that number was 25% now. That's still not acceptable. Completing an IEA on a person should be absolutely the last resort. This legislation is not meant to extend the time an IEA patient spends in the ER. It is meant as a tool for the provider to hold an unsafe person for up to 3 days whose condition is not related to a serious mental illness and get them on the right path. That may be substance abuse rehab, that may be long-term care, or that may be a voluntary unit. Despite providing extensive education to the hospitals and the providers just a couple of years ago, just in the last 3 weeks, I want to read you the numbers from New Hampshire Hospital. Now, I do want to note that the average wait time right now is less than a day. So everybody that was put on the referral list yesterday is in the hospital if they met IEA criteria. We have approximately 7 people referred today. They will all be admitted this afternoon if they meet IEA criteria. So in the last 3 weeks, with an average wait time of 1 day, New Hampshire Hospital has deferred 25 patients. 3 of them were deferred because they had a developmental disability and their behaviors were related to their disability. 15 were deferred because of substance use. 3 were deferred because they were voluntary patients and didn't need to be IEA'd. 3 had other reasons, and 1 had dementia. In addition to these 25 patients that were deferred, 19 patients had their IEAs rescinded prior to coming to New Hampshire Hospital. Now, granted, this is an average of a 1 to 2 day wait, so their IEAs are being rescinded within a day or 2. These are obviously patients that do not need to be IEA'd. The reason we put this legislation forward is because we want to give providers in the emergency room up to 3 days the time to fully assess the patient on whether they need an IEA. If they come in and they're under the influence of alcohol, allowing them to sober up and determine the right path for success is important. They should not be subjected to an IEA. I've received calls from all of the impacted stakeholder groups and advocacy groups. Pretty much every one of them we've talked to about this legislation. They all oppose it. I know that. There is a lack of support for this. I asked them all the same question. Okay, if not this, then what? We have the funding. We have the support. What's the resolution? Not one person could put a resolution on the table. Not one. We've had an ER boarding crisis for 10 years now. It is time to fix it, not talk about fixing it, actually fix it. I'd like to introduce Jonathan Ballard. He is our Chief Medical Officer at the department, and he's going to give you a physician's perspective on this legislative request.
Good morning, Mr. Chair and committee members. For the record, my name is Dr. Jonathan Ballard. I work as the Chief Medical Officer of the Department of Health and Human Services. I'm a member of the Board of Medicine, and I've been a practicing physician in emergency room settings, taking care of patients with serious mental illness and gone through the involuntary emergency admission process with patients over a number of years at least 3 different hospitals. when my patients have come in, oftentimes in crisis with mental illness, initial workup must be performed. We have to determine whether that mental illness is a result of a serious mental illness such as schizophrenia or depression, or is it a result of an underlying condition, a medical cause for their altered mental status that could result in a mental illness that poses a likelihood of danger to themselves or others. Certainly, these patients need care and they need to be placed into a safe environment. However, an involuntary admission to a mental health hospital is not always the right answer. If their mental health illness is a result of a medical illness, such as an acute intoxication to drugs or alcohol, or an altered mental status from an underlying medical condition, such as electrolyte disturbances or an acute stroke, we need time to be able to assess their condition. Right now, with the recent ruling, there's a serious question of whether or not I can complete a full workup of a patient when they do pose a danger to themselves or others. If the involuntary emergency admission results in a requirement to complete the IEA form and transfer to a mental health hospital, there's no longer an ability to perform that medical protective custody in a safe setting in the emergency department while the underlying medical evaluation is undertaken. We need a tool urgently to be able to allow for the safety and medical evaluation of our patients. I think that's one underlying reason why this is a pressing issue for us to bring forward to you today. Thank you.
Thank you. Melissa, do you want to add anything?
I don't have anything to add at this time, but certainly am available for questions.
Okay. Are there questions of either Dr. Ballard or Commissioner Shibinette? Senator Whitley.
Thank you, Mr. Chair. And I just want to start off in, recognizing all of the work that the department and the commissioner has done to bring folks together and try to solve this problem. It has been intractable for decades. And, I just want to recognize that I see that work happening. We all do. And that we're all, I think, at a point where we want to be solutions oriented and not place blame or anything like that. So, and I understand, that it is clear to me, that this legislation was brought forward to, look through, make sure we don't have any inappropriate IEAs because of, how significant it is. But it just seems to me that, this solution, maybe doesn't get us where we need to. But what it does do is, increase the time that folks are held without due process. And so I certainly recognize the issue, but I'm wondering if maybe we've also considered some other alternatives. I know for a long time, work groups have talked about doing sort of an augmented triage of the wait list. I know this was done in the past, so I'm wondering if this has been considered recently.
Good morning, it's Lori. New Hampshire Hospital does that triage of the wait list, if not every day, at least 3 or 4 days a week. That's where the 25 deferrals come from, is that they do a huddle to do the triaging of the wait list. That's the population we're targeting, is the population that shouldn't have been IEA'd to begin with, right? They're intoxicated and they're coming in on a Saturday night, and the provider's unsure, so they IEA them, and by the time they sober up, they can rescind the IEA and they leave. That's the population I'm targeting. I absolutely agree. If someone with a serious mental illness walks into the hospital, an IEA should be completed immediately. That's not the group that we're trying to target here. This is the people that shouldn't be. So we do the triage at the hospital, which is how people get deferred. A triage with all of the hospitals on a call, that has not been done.
So just a follow-up.
Okay.
So Commissioner, thanks for that. And, are there any additional barriers for standing up a more augmented triage wait list? Are there any policy barriers or resource barriers to stand that, to make a more robust augmented triage?
I'm not aware. There's no policy barriers or operational barriers there. I guess, based on my conversation with our different partners is what is the goal of that type of triage, right? What is the goal? All of the DRFs that have open beds get the wait list every day. They know who's on the wait list. They get the same referrals we do. They're able to take people off the wait list and fill their beds, which they are doing for the most part. So if no one has open beds and there's 30 people on the wait list, I'm not sure of how that's going to what value that's going to bring, because as of right now, if a hospital has an extremely violent patient or a patient that's extremely sick, they call Dr. Fetter at New Hampshire Hospital and we triage them to the top of the wait list. I mean, that triage happens now at the hospital level. So I don't think that, and it's not just me, even the other partners understand the goal of doing that wider spread triage.
Thank you. And I have one last question, if I may.
Okay, go ahead.
Thank you, Commissioner, and thank you, Mr. Chair. So the other question that I have is just sort of thinking through. It's great to hear where we are with the adult wait list, and so I'm just wondering if you could share with us the steps that were taken to get that wait list to where it is today, and sort of what's happening on the kid side as well.
Sure. So a couple of weeks ago, we offered incentive pay to long-term care, which have been great partners. They showed up at our door and committed to taking at least 25 patients from New Hampshire Hospital, which essentially empties J unit, which is our geropsychiatry unit, that opens up 24 additional beds for adults. And those patients get to go live in their communities in long-term care centers. We took our temporary kids unit and we converted that back to adults, which opened an additional 10 beds. So those two solutions resulted in increased capacity. Now, we have done this before. This is not the first time we've increased capacity at New Hampshire Hospital by changing our the type of patient we take care of. When we moved the kids to Hampstead, we increased capacity. Our wait list hit 0 then too, and then it came back up. We opened transitional housing last fall. Our wait list went down and came back up. This is kind of the last flexibility I have within the population at New Hampshire Hospital to create additional capacity. What we have left is there are hospitals that have either expressed interest or commitment to open additional DRF beds, somewhere between 25 and 30. So we'll be asking for a letter of intent from them today once that incentive program passes fiscal, and hopefully we'll have those up by the end of the year. When it comes to the kids, Hampstead is still providing our entire children's services. They are still down a unit due to staffing. We're in contract negotiations with 3 border hospitals to take some of our referrals. And we are in the middle of negotiation of increasing children capacity substantially in this state, but I can't get into further details on that just yet.
All right, one follow-up from that answer, if I may.
Okay.
So thank you, Commissioner. That's helpful to know. And, I know that you are committed to addressing the front door problem, and you have been very clear that, adding bed after bed after bed doesn't solve the whole problem, right? You have been very clear about that. And for that, I really appreciate that. Really, the problem is standing up the community-based services. So can you share what the ongoing barriers are to standing up at a minimum mobile crisis units?
Mobile crisis units are in the process of being stood up, and additionally, we are negotiating with the CMHCs to stand up an additional 60 transitional housing community residence beds. And Senator Whitley, you are correct that the fast and easy solution to this problem is to just build beds. I mean, that's what we did 50 years ago. That's why we had 3,000 beds on the grounds of New Hampshire State Hospital, right? We made the promise 50 years ago that people with mental illness would not have to live out their life in a state institution. We said you are going to get community care in the community by the community. So, you know, when we hear that this is a state problem, it's very upsetting to us because it's not a state problem. These people deserve to get their care in their community by the community. Our communities can't select which parts of the population they're going to take care of and which parts of the population they're not going to take care of. And right now, there is a dearth of services in the community, specifically around supported housing, around mobile crisis. All of those are in the plans. And to be honest with you, you know, we crafted a plan. We crafted the 10-year state mental health plan. It's a great plan. We put a children's system of care in place and contracted that out. It's all of those pieces of community care that we need to fix this problem. The issue is that it was going to take several years. And when the Supreme Court gave us the order, they didn't say you need to be in compliance in 12 months. They said you need to be in compliance today. I mean, the very next day, they started throwing out probable cause hearings because of the 72-hour rule. And we managed with each individual patient to make sure that that patient was in a safe environment. But we didn't have a period of time to become in compliance with that order. So all of those plans that are 12 and 24 and 36 months out all got expedited very quickly to say, how do we become in compliance? And we've been in compliance for the last 2 weeks or so because of the very quick changes that we made. But what's right for the patient and what's right for the citizens of New Hampshire is care in the community by the community. It is not care by the state government. It's not care in a state institution. It is care in their home community.
Commissioner.
Other questions, Senator Gray.
My question is about the status quo with the court order. As I understand it, the court order says you have to have the hearing within 72 hours. So you hold the hearing, you find that the person needs to be retained somewhere for their own good. Is it an option to leave them there in the hospital until a bed becomes available?
No, once probable cause is found, they are in the custody of the state mental health system. So no, it would not be feasible to leave them in the hospitals. The hospitals are also not willing to do the hearings. So they have to come to New Hampshire Hospital or another DRF to have the hearing. And then once they're there, they have to stay there.
I follow up if I could.
Yep.
The hospitals are not willing to hold the hearings, and they're not willing to hold the people after the hearing. Or is that what I heard you say?
They're not willing to hold the hearing. We had explored this back about 2 years ago, right before COVID, whether we could do IEA hearings in the emergency rooms, and the hospitals were not willing to do the hearings. They felt like there was a liability and a safety issue there. I don't disagree with them. Once the hearing happens, so what would, if we had the hearings at New Hampshire Hospital, you would have to transfer all these patients from all over the state to New Hampshire Hospital or to another DRF to have the hearing. Once the judge finds probable cause, then the law says that person needs to be in a DRF, and they are in the custody of the state mental health system, which means we are responsible for their care. Melissa St. Cyr, who is the lawyer, probably can give a more legal explanation to this if she wants to chime in.
So let me just follow up, if I might, on that question. What happens then you know, they've had the probable cause hearing and they're in the care of the state, but there are no available beds.
They only have the probable cause hearing when they get to a DRF. That's why we're in the position we're in right now. Is that the only place that they have a probable cause hearing is at New Hampshire Hospital or an established DRF. There's no hearings anywhere else.
Okay, but what happens then, take it a step backwards, there are no DRF beds or at the hospital, and isn't there then an inability to conduct the hearing? What happens then?
Yes, that's exactly that's what led to the lawsuit was
Exactly, but then
yeah.
would you have to release that patient?
The judge
If
will
you couldn't
find.
hold a hearing?
Yes, so when the hospital would have the option of releasing the patient, or the hospital can transfer them to New Hampshire Hospital, and we have the probable cause hearing after the 72 hours, which has happened the first week that this order came out. In most cases, the judge found no probable cause because it went beyond 72 hours. And we worked with each individual patient to make sure they were in a safe environment. Either we could re-IEA them because they displayed unsafe behavior at the hospital. They agreed to go voluntary, or they had a discharge plan that we could live with. But Melissa, go ahead and chime in.
Thank you. So thank you. For the record, Melissa St. Cyr, Chief Legal Officer for the Department of Health and Human Services. So currently, when the IEA certificate is complete, and what the court ruled is that when the IEA certificate is complete, they are in state custody at that point. So the certificate is completed at the hospital. The certificate at that time, because it initiates the being in the state mental health system, the law says that they need to be immediately transferred to a DRF or New Hampshire Hospital. And because we don't have beds available, they are then sitting at the hospital waiting for a bed to become available. That hasn't occurred, as Commissioner Shibinette had pointed out. That has not occurred over the last few weeks, and we've been in compliance. However, if we don't have, if the wait list starts to creep back up again, and individuals are waiting in the hospital after their certificate is complete, they are in state custody, and therefore they need a probable cause hearing within 3 days of that certificate being complete. If they aren't transferred to us right now, the probable cause hearings aren't occurring. They wouldn't occur until they got to a DRF, and a court hearing is then scheduled. And at that point, as Commissioner Shibinette pointed out, they would most likely be, denied by the probable cause hearing, would find that there was no probable cause because of the fact that they did not receive a hearing within 3 days. And so that's the danger, right, of this not having enough beds, not having the community support on the back end to be able to provide these people the support that they need, because they're not getting the care that they need in their community, and we have to rely solely on them being admitted to the DRF or New Hampshire Hospital.
And if there weren't a bed available, then it's at that point they could be released.
They could potentially be released if the hospital chooses to do so. They could be as Commissioner Shibinette pointed out, they could do a new IEA if they've displayed new behaviors since the initial IEA certificate was completed. They could choose at that point, because if they have received any treatment, we do see that people that have received treatment now understand that their mental illness requires treatment, and therefore they choose to go voluntary. And so we can ask them to do that. We can work on guardianships, and there's avenues that we would take, but yes, there is a danger of release. Okay,
all right, Senator Whitley and then Senator Gray.
Thank you, Mr. Chair, and thank you, Attorney St. Cyr, for taking my question. So just going back to this due process issue, of course, like what have you heard from the hospitals that are the barriers to getting this due process done?
Specifically, are you speaking of getting the probable cause hearing done while individuals are in the hospital?
Correct.
as Commissioner Shibana pointed out, they believe that there's a liability, there's safety issues. They're not comfortable with probable cause hearings being conducted. If the individual becomes, upset about the fact that if their probable cause is found while they're in the hospital, they won't maybe not be able to manage them. I think that question may be better asked of the Hospital Association, which I'm sure that they are on this call.
Thank you.
Senator Gray.
So the way that I read paragraph 2 of the bill, what this does is it allows you to put him in medical protective custody for up to 7 days, extension on what the court has ordered for the hearing. Is that correct?
No. So we did request that 7 days got changed to 3 days. So we're requesting 3 days of medical protective custody. This has nothing to do with the courts. This is for someone that comes into the hospital and the provider, the physician, doesn't know exactly what's wrong with them. They may have drugs in their system. They may be homeless. They may be coming in saying that they want care. What this does is it gives the provider 72 hours to figure out whether an IEA has to be done, whether there's a different care option for them, whether they need to consult with another type of physician, that type of thing. It gives them an option to hold someone. Because what I've heard from physicians when I was at New Hampshire Hospital and we would do all these deferrals, we would get referrals for someone that had a substance use issue. Or that was intoxicated, and I would call the doctor and the doctor would say, I understand it's not a mental illness, but I have no other way to hold this patient other than an IEA. There's no legal way for me to hold this person other than an IEA. I'm trying to give the providers this tool to say, I can hold this person on a Saturday night who is under the influence and assess them in the morning or assess them tomorrow when they're no longer under the influence and decide what the right treatment option is for them. Because oftentimes what's happening is they'll do the IEA and by Monday, they're rescinding the IEA and sending them home. But meanwhile, my wait list at New Hampshire Hospital has gone through the roof for 2 days because of all these people sitting on the IEA list not appropriately. Last week, we had one of the people that did not get in within 3 days was in ICU. And the provider did the IEA because they wanted to get them on the list just to make sure that they had a bed as soon as the bed opened. But the person wasn't even ready to come. They were in the ICU. So providers are doing the IEA certificates to get people on the list when they don't even need to be on the list. So this is giving them an avenue to hold them so that they don't have to do an IEA certificate.
Senator Gray, this is Jonathan Ballard. May I add to that? There's so much stigma associated with mental illness and involuntary emergency admissions. And many of my patients in the past, I think would have greatly benefited from an option that did not involve going to a state mental health hospital, to having their rights taken away from them, and then living the rest of their life, with the idea that they've been admitted to a state mental health hospital, both personally, but then also in some situations going forward with jobs and continuing a life. So as a provider, I would, need time to help my patients obtain the resources they need to be successful, work on if it's an underlying medical condition that can be resolved. And right now I don't have that tool set to do so, and it results in a less than ideal situation for both that patient, but sometimes for the rest of their life.
Further questions, Senator Gray.
So what I'm hearing is that really, instead of this bill, what we need is a way for the doctor to say, I think that there's a drug or alcohol condition or whatever you want to put on that list that allows them to hold them for 24 hours or whatever. And then you really don't even need this. Am I wrong?
No, I think that's exactly what we were shooting for, is giving a tool to the provider to say, I need X amount of time, we said 72 hours, to do a full assessment, do labs, do x-rays, MRIs, get a consult if we need, to assess where this patient needs to go. Nothing precludes a provider from doing an IEA immediately. But what we're trying to do is give them the time so that they don't have to do an IEA and still legally hold them there to do the assessment.
Follow up on that.
May I also?
Gray.
The problem that I have is that in the citation, it says meets the criteria of RSA 135-C:27, Roman 1 and 2. And again, I'll have to go back and reread that again. But if we're evaluating for drugs and alcohol, et cetera, is that the proper statute to be citing? And wouldn't we be better off citing some other statute?
Alyssa?
So thank you for that question. We are, we have under 135C:27, danger to themselves or others and mental illness are not the same thing. And so RSA 135C:27 speaks specifically to an individual who's a danger to himself or others. And so we were trying to use that as the framework. So it's not necessarily that they have a mental health concern, but that they are a danger to themselves or others at that point. So that's what RSA 135:27 references. And so we want to ensure that if somebody does arrive and they are a danger to themselves or others because of, that they've done certain things, then, they're under the influence and they attacked a police officer or something along those lines, and the police officer was concerned about their well-being, brings them to the emergency room. They don't have a history of mental illness. However, they clearly are a danger to themselves or others at that point, that they can hold them, assess them, and take care of them. So, certainly we can look at 135:27 if there are concerns about that reference. And if we want to make it clearer that it's specific just to a danger to themselves or others, and pull out any references or anything like that to mental illness, we can certainly make that change as well.
That was my point. So thank you for the questions and the answers.
Senator Whitley.
Thank you, Mr. Chair, and thank you, Melissa. So I have similar concerns to Senator Gray. We agree that this is an issue that needs to be addressed, but is extending the time period for patients to be involuntarily detained in ERs without a hearing and without treatment, may I add, is that the best solution to this problem?
So I wouldn't think that we were extending an involuntary emergency admission specifically. And that's what we've been trying to articulate, maybe not very well, but we're not looking to extend a time for somebody who's IEA'd to be in the hospital. We're looking for an individual who the medical professional looks at and says, I don't think that this individual should be IEA'd. However, I think that it's important that that I hold on to them. I think that they are a danger to themselves or others. And so therefore I need to be able to assess them, to treat them appropriately. And it's that population, not the population of the individuals, who they believe need to have an IEA, that we're talking about here. And so like I said, we can make it clearer in the language, maybe not to reference the 135C:27 and define a danger to themselves or others, but that, the doctors who have said to us, we know that this is not an appropriate IEA, but we have no other way to hold on to this individual, that we allow them to do so.
One last follow-up, if I may.
Go ahead.
So I am confused because the way that I read this, it seems to create a legal status, basically a right to be held before the IAA process. Isn't that correct?
That is not the expectation. No, this is for individuals who would not be subject to the IEA. And I think that the reference to 135C:27 is what's the confusing part there. So I think that we may need to look at that language to make a change to ensure that it is clear that it is for those individuals who are a danger to themselves or others, but the physician does not believe at that point in time that an IEA is appropriate.
Right, because they're still being involuntarily held. I think that's the point that's tripping us up also.
Yeah. So there's the difference between the involuntarily held, it's a protective custody hold versus the IEA hold. And we look at them as two separate things.
They're two separate paths. And what's important is that these patients are being held right now They're just being held on an IEA, and then the IEA is being rescinded or deferred because they're not appropriate for an IEA. We're trying to give a parallel path for those that are a danger to themselves or others, but not because of a serious mental illness. Now, will there be times where maybe someone comes in intoxicated and the doctor takes a day or two to do that assessment, and then they determine, yes, an IEA is appropriate and they do it? Yes, that could definitely happen, and that would extend their time. But what the intent and the target for this is for those people that are carved out that should not be IEA to begin with, to give the providers a tool to hold them for a couple of days to do the assessment. And like Melissa said, we can go back this afternoon and tomorrow morning and revise this language to make it more clear that this is not intended for the people that are going to be on an IEA. We want those people, and you know, inpatient providers or ER providers know who these people are. They've been in their ERs before. They walk in, they can see that they've decompensated. They know they're going to need an IEA. They can do those the minute that person walks in. That's perfectly okay, and we want that to happen. It is the other people that don't need to be IEA that we're targeting.
Commissioner, just one other thing before we get on to the next witness. Section 1, private entity. I mean, we've gotten a lot of feedback on that. That's also not positive. Can you comment on that?
I can't imagine why anyone, based on the state of our mental health system, why bringing in any provider that could bring in additional resources, additional expertise, and potentially additional workforce would oppose this legislation. I mean, that's ultimately what I'm trying to do. Is there's national providers of mental health care all across this country. And what I want to do is go and find those people that maybe have a different way of providing it. They can bring people with them. They can provide an entire continuum of care and bring them into our state to add additional capacity in our community mental health system. They would have to follow the same rules and regulations and expectations as the CMHCs. I'm not trying to replace the CMHCs. I'm trying to add to our pool of capacity and expertise in the community mental health arena.
Okay. Seeing no further questions, I'm assuming at least some of you will stay on if we have questions after we've heard from the long list of other speakers. So thank you very much, Commissioner and Dr. Ballard and Melissa. Okay, next, if you could bring in Ken Norton.
Good morning,
Ken should be
Tim
in.
and Bradley and members of the committee. Thank you for the opportunity to testify. My name is Ken Norton, and I'm testifying on behalf of NAMI New Hampshire, the National Alliance on Mental Illness. And I would just start by saying that although it's been 20 years since I've done mental health assessments in emergency rooms, that I did them for many years and led the team at Lakes Region Mental Health, covering both Lakes Region Mental Health Center and Spear Memorial Hospital. So I'd like to start by saying that although it's getting overshadowed, and to your question, Senator Bradley, by the medical protective custody part of the bill, NAMI New Hampshire is supportive of the language in Section 1 regarding the addition of private entity to the definition of community mental health programs. It's long been our hope the state would consider this type of private entity to provide statewide mobile crisis response services, but we believe that New Hampshire can benefit from any qualified and willing provider. As for Section 2, adding a medical protective custody component to involuntary emergency admissions, or IEAs, on behalf of NAMI, I would like to speak in opposition to the section as proposed. While I mentioned that it's been 20 years since I've done emergency assessments, it's only been 10 years that emergency department boarding has existed. And I want to make that point clear, that and that in the 25 plus years up until 2011, every person who met the criteria for an involuntary emergency admission was admitted to New Hampshire Hospital within hours. I would say, 95% of them within 6 hours of walking through the door of the emergency room. And that included the assessment and then the transport from whatever part of the state to New Hampshire Hospital. As part of that process, that included the person first being medically cleared by the emergency room staff. So I, for instance, wouldn't be called, or I might be called to say, hey, heads up, it's 2 a.m, we have this person, so start to get ready. But I wouldn't be called until they were medically cleared. If they went to the ICU for an overdose or some other situation, then the assessment wouldn't be done. Individuals who were intoxicated and determined to be a danger to themselves or others were routinely placed in protective custody in the local jail. And when they were sober, the jail then made the decision whether they needed a mental health assessment. They were never IEA'd while intoxicated. The major problem with this proposed amendment, in our opinion, is that it's fatally flawed. The flaw is that it presumes mental health treatment is available in emergency departments. Simply stated, it is not. While there are 2 or 3 hospitals who provide some limited mental health treatment in emergency rooms, the clear majority provide little to none. If you've not already done so, please review the testimony submitted to you by former NAMI New Hampshire board member Karen Trudell of how disturbing it was for her to be held in a windowless room in Yellow Pod at Concord Hospital, alone with her destructive thoughts for days at a time. And I would add that Concord Hospital is one of the better equipped and staffed emergency departments to deal with people in a mental health crisis. NAMI New Hampshire truly wishes and believes there should be more mental health treatment available in local hospitals where people can receive appropriate and timely treatment closer to their families and their natural community supports. We believe if more voluntary psychiatric hospital beds were available, there would be many fewer IEAs and people would be afforded more dignity, as Dr. Ballard testified. We have stated on numerous occasions that the care of people with serious mental illness is not the sole responsibility of the state, and that local hospitals and commercial insurance providers need to do more in order to provide comprehensive and local mental health care. However, enacting this medical protective custody provision without first ensuring that treatment is available at local hospitals will likely mean people in a mental health crisis will languish again for days while they wait for inpatient admission. And albeit the commissioners and the previous testimony from Melissa clarifies some of that, and I'll speak to that in a second. NAMI New Hampshire also has other concerns that, including the amendment, which I think have been raised by Senator Gray and Senator Whitley, that it does not contain any structure or provisions to safeguard the people who clearly need to be immediately admitted to a designated receiving facility won't be placed into this medical protective custody category and have their admission delayed. In fact, the amendment as proposed sets out no criteria to determine who should be transferred immediately and who should be held in protective custody. We also have concerns about people's due process rights, but we'll defer those concerns to legal advocates who can better address this issue. New Hampshire Hospital has indicated many of the IEAs they receive are not appropriate, and they cite 2 major cohorts of people who are being IEA'd who don't necessarily meet the criteria for admission. These include individuals who are intoxicated or have some type of substance use-induced psychosis, and people with dementia or other types of organic brain disorders, trauma, who are not diagnosed with a major mental illness. While there needs to be more discussion specific to these populations and their medical needs, NAMI New Hampshire is willing to consider supporting a medical protective custody provision for people with these conditions with specific language that it does not apply to people with a serious mental illness. In citing some of the reasons for proposing the medical protective custody provision, Commissioner Shibinette has cited the high number of IEA hearings which are dismissed, waived, or no probable cause found. While there may be a number of reasons for these dispositions, particularly hearings that were waived or dropped, the number of hearings where no probable cause was found is a serious concern and may indicate people are being inappropriately IEA, to the Commissioner's point. And in the testimony which I sent you, and I did send a revised one because one of the charts had a block on some of the key data. The data below was provided to NAMI New Hampshire by a reporter who who obtained it from the circuit courts, indicates that for 2019 and 2020, that over 10% of the cases, no probable cause was found. And I would note that for those of you that have been on the committee for a bit, this is more than double the number that was presented by Judge Kelly at a 2017 hearing about due process. So at a minimum, this indicates a need for more training of emergency department staff and providers, as well as, and I think Senator Whitley was getting at this, a stronger review by NHH or designated triage person prior to admission to ensure that forms are properly filled out and people truly meet the criteria for an IEA. It's important to note that this has been an extremely challenging year for everyone due to the pandemic. Components of the 10-year mental health plan, which DHHS had prioritized, and you, the members of the Senate Health and Human Services Committee, had championed and led through the legislative process, have been delayed. And sadly, the mental health impacts of the pandemic have exacerbated the emergency department boarding crisis in multiple ways. Although I will admit I was initially shocked by this proposal coming so soon on the heels of the Jane Doe decision, I believe the commissioner and the department have the best of intentions in bringing this amendment forward. Having spent the better part of the past week talking with key stakeholders, including DHHS, it's clear we share a common goal. And that goal is for people in a mental health crisis who have been determined to be a danger to themselves or someone else to receive timely access to treatment, which will ensure their care, safety, and well-being, as well as the safety of the general public, and that they are also afforded their due process rights. As providers, advocates, and key stakeholders, we don't necessarily agree on how to do that in the short run. It's hard to not look back over the length of this emergency department boarding crisis and identify points where we could have or should have intervened, but there's nothing to be gained by looking back. We must look forward. For the most part, we do agree that the steps DHHS, the governor, and you, our bipartisan leaders in the legislature, have taken prioritize the key recommendations of the 10-year mental health plan and are making significant strides in building a comprehensive community-based system of care. The gains we've made in the months since the Jane Doe decision in bringing the adult emergency department boarding list down to single digits and even zero may not be sufficient in the long run, as you just heard testimony from the department on, to remain in compliance with the Jane Doe decision while bridging the gap until we can operationalize additional mobile crisis response teams, designated receiving facilities, and community residential program beds. In the 29-page amicus brief, which NAMI New Hampshire submitted to the New Hampshire Supreme Court, we ended our brief with the following two sentences. NAMI New Hampshire also respectfully cautions the court that it would not be in the public interest to force release of patients who are in fact a danger to themselves or others. Any relief provided by this court should be prospective so that those bound by the court's order will have adequate time to assure that dangerous patients are not released on a technicality. We believe the potential for people who are a danger to themselves or others being released on a technicality is what we may be quickly heading toward and what Commissioner Shibinette is trying to avoid by proposing this medical protective custody amendment. While we cannot support the amendment as currently written, we're willing to immediately work with this committee, DHHS, and other stakeholders to identify modifications or alternatives to HB 565 as proposed. As this is likely the last public hearing of the Senate Health and Human Services Committee this year, on behalf of NAMI New Hampshire, I want to sincerely thank you all for your bipartisan leadership over the past few years to reform NAMI New Hampshire's mental health service delivery system. Thank you for the opportunity to testify, and I'm happy to answer any questions which you have.
Senator Gray.
So if I go back to what the department said, that there are a number of people who need to be, for their own good and for the society's good, retained for a certain amount of time. It would seem that if we restructured this to do that, we would get them out of the statistics and be able to better focus on the people who do have mental illness. Do you believe that a way to retain people who are a danger to themselves, in Melissa's words, is appropriate and should be done?
Thank you for your question, Senator. I think that it's it's hard to sort of parse out and sort out who these populations of folks are. But from NAMI New Hampshire's perspective, if it was clear that people who met the criteria as currently established for being a danger to themselves or others were immediately processed as an involuntary emergency admission, and there was some clear separation of this other group of folks who may pose a danger to themselves for other reasons, that we would be supportive of this medical protective custody.
Thank you.
Senator Whitley.
Thank you, Mr. Chair, and thank you, Ken, for your testimony and taking my question. So, I think it's pretty clear that we can all agree, of course, that ensuring public safety is important, ensuring the safety of an individual who might be dangerous to themselves, that's critical. But I think, we can also agree, it sounds like that this amendment doesn't solve that problem. And, just kind of extends the time period that folks are involuntarily, detained without hearing. So, but, I think we have heard some additional solutions that may be better instead of, taking away due process rights, right? So at this point, we should be increasing due process rights, not taking them away. So, you had mentioned this medical clearance process. And so I'm wondering if you are aware of any financial or policy barriers to, one, the sort of augmented triage proposal that many folks had talked about, to this, sort of assessment that's really required, this medical clearance. And as the other thing, the sort of training you mentioned of ERs. Are you aware of any policy, financial barriers to those three potential alternative solutions to this amendment?
Yeah, I may not be the best person to speak to. Thank you for your question, to those barriers, but I certainly, I would generally say no. I think that I think that the rise in number of cases where no probable cause is found certainly indicates, speaks to part of the problem of what the commissioner is describing, that, that people are obviously being inappropriately IEA'd. So I think a more intensive triage process or review of that, which may include a copy of the IEA petitions immediately being sent to New Hampshire Hospital or to the department for review, would be helpful in this process.
Thank you.
Okay, thank you very much, Ken. Next, Kirsten Griffin, if you can bring in Devin Chafee or Gilles Bisonet from ACLU.
Hold on, I'm looking for Gilles Bisonet right now. Gilles, if you, never mind.
Thank you, Mr. Chairman. Can I be heard?
Yep.
Oh, wonderful, wonderful. Thank you, Chairman Bradley, so much for the opportunity to testify today. My name is Gilles Bisonet. I'm testifying this morning in two capacities. First, as the legal director of the ACLU of New Hampshire, and second, I'm testifying in my capacity as class counsel in the federal class action case John Doe versus Commissioner, which was filed here in federal district court in November 2018. And in that case, I've been appointed to represent the due process rights of all persons who are currently have been, or will be involuntarily detained in a non-DRF hospital without receiving a probable cause hearing within 3 days of the completion of an IEA certificate. And in that role, I would also note that we authored an amicus brief on behalf of the class we represent in the New Hampshire Supreme Court case Jane Doe that I know has been mentioned earlier this morning. We've been trying, like other stakeholders in the legislature, to have this wait list issue addressed for years. I'd also note that due process, of course, is not a mere technical or procedural right. Rather, it's a bedrock constitutional principle. Frankly, if you're being detained involuntarily, we believe that you should have the opportunity for a prompt hearing to contest your detention. And that's why we filed our federal lawsuit. And that's why, as well, we've submitted proposals of our own over the past several years to try to address this crisis. First, I'd just like to testify on the proposed amendment. And let me just say, too, at the outset that We very much appreciate DHHS's efforts to ensure that only those who really need to be detained are subjected to the IEA detention process. Let me give you 2 data points that I think support this concern that some people may be going through the IEA process unnecessarily. So in 2017, DRFs discharged 162 patients after they were transferred to a DRF before their probable cause hearings. And in 2020, there were 252 cases in which no probable cause was found, and that was just over 12% of the total number of IEA petitions filed. So that is really why due process matters for these individuals, and why I think the commissioner's objective of allowing early intervention is an important one, because of course, the more people we can divert away from ERs and the IEA process, the lower any future wait list may be for DRFs. And this will also help ensure that we are only using DRF beds for those who truly need help. And of course, with that, this will help ensure that with the reduction in any potential future wait list, those who need help and need to be subjected to an IEA will immediately get delivered to a DRF and quickly get the help that they need, which is so critical. We do, however, oppose the amendment as drafted. And this is because as we read it, it creates a new detention system that could potentially run consecutively with the current 3-day detention scheme, and as a result, increase the number of days that a person could be involuntarily detained in a hospital ER without due process, whether it's an additional 3 or 7 days beyond the current 3-day window. I do want to note, though, that we don't oppose a custody review process along the lines of what DHHS is proposing after the certificate and petition is completed, including after the physician's assessment. But we think it really needs to happen within the existing 3-day window and not add time to a person's detention in which they are not receiving a probable cause hearing. And so second, along those lines, we wanted to just broach 5 proposals for the committee's consideration. And I know I sent this to the committee yesterday evening. I know it's short notice. I would note that we also, as soon as we sent these to the committee, we also sent a copy to DHHS, Council for the Hospital Association, the court system, and other stakeholders. We don't expect, of course, anyone to have final positions on these proposals, but we wanted everyone just to have access to provide feedback for discussion purposes, because I do agree with the commissioner that we all really should think creatively and constructively about whether there are policy changes that we can be made to help address this particular issue. And the first proposal in my written testimony, frankly, I think is actually closest to DHHS's amendment and consistent with their intent to allow for some review to ensure that the IEA process is only being used for those who need it. So under our proposal, a person who is subjected to an IEA would be able to ask for a custody review after 24 hours. That would, though, still occur within the existing 3-day window. And so this would allow DHHS to act in a triage capacity, as to some extent a gatekeeper for the IEA process, but it would do so without prolonging a person's detention without a hearing. And I think, to answer your question more directly, Senator Whitley, I actually don't think there's currently a policy bar to this kind of triage role, but perhaps codifying it in some way could help. Under our second proposal, we believe that the department should receive the IEA certificate and accompanying paperwork once the certificate is completed. Some of this might actually already be happening, but this would include when the petition is being boarded in a hospital emergency room. This would become important if the wait list emerges again in the future. This would not only, again, give DHHS the ability to timely appoint counsel while a person is waiting in an ER, but also, again, would give DHHS the benefit of intervening in a triage capacity. And further, this proposal would allow DHHS and the circuit court to begin the process of scheduling a timely probable cause hearing, even if the person's in an ER. Now, I know that, at least for adults, the waiting list is 0, but my fear has always been that we are going to have it again in the future. Over the past several years, it has, reached 0, maybe on a 1, maybe 2 occasions, and then the wait list has only gone up. So I think thinking about how to envision a system that accommodates due process if we have a wait list in the future is important. Under our third proposal, and again, to provide greater flexibility to ensure that due process is timely provided, and also frankly, to ensure that patients who are a danger are not released because of a failure to hold a timely hearing. We also wanted to recommend that an amendment be put in that makes clear that PC hearings can occur regardless of the patient's location. The fourth proposal is that currently IEA patients only receive a notice of their rights after they're being transferred to a DRF. That could be, of course, as we all know, weeks after they're initially detained in the hospital emergency room while we've had a wait list. We just think, frankly, that patients are entitled to this notice promptly and immediately so that they're aware of their rights in the event their detention becomes prolonged. And lastly, we've recommended that the statute be amended to create an expedited right of appeal. And I just want to be transparent. I did speak this morning with Attorney Richard Head, who represents the court system. I know he's on the line today. He did notify me that the court system was in opposition to that fifth proposal due to resource concerns. But I do think this proposal really needs to be on the table in looking at the due process rights holistically of this population. And this is really, I think, an important proposal because the current IEA statute doesn't explicitly provide for an expedited right of appeal. A patient's right to appeal the circuit judge's decision is effectively meaningless in this instance because given that appeal can take up to a year, any appeal would likely become moot as a person's mental health status changes. And so as a result, few IEA patients take advantage of their appellate rights. And our proposal is actually modeled there after the judicial bypass process for the committee's consideration. So with that, I'll conclude my testimony. Again, to be clear, we're happy to work with all stakeholders on this issue in order to ensure that IEA patients get timely due process. Thank you.
Other questions of Jill? Senator Whitley.
Thank you, Mr. Chair, and thank you, Gilles, for taking my question. So, well, you did answer my question on, the potential barriers to these other solutions that we're all talking about today. That's helpful. So, in looking at the fourth proposal regarding notice, is it the case that folks don't get notice in the ER right now if they're being held?
Yes, they only receive that notice document under that statutory provision once they're admitted to the DRF. Now, if an individual is immediately delivered, right, that's not necessarily a problem because they're getting notice in a timely fashion. But when you have a wait list, that becomes a real serious problem if you have a person, say, waiting a week or two. They have no idea what their rights are because they're just not getting that document until they're ultimately transferred.
Thank you.
Okay, seeing no further questions, thank you very much.
Thank you.
Jim, can you take over for a minute, please? And
Sure.
I think the next was Mike Skibby.
When are we going to go to the time limit, or are we?
After Mike and the Hospital Association. I'll be right back.
All right. Go ahead. Griffin?
Morning. Mike Skibby from the Disability Rights Center. Thank you for hearing my testimony this morning. The Disability Rights Center cannot support the proposed amendment because it removes important protections against improper confinement in emergency departments, but it does have elements that could form at least part of the basis for a reduction in the unnecessary use of ER boarding for people who do not meet the legal standard or could have their needs met in a less restrictive setting than the hospital or another DRF. I want to just say that I'm going to skip over parts of my outline because I'm kind of perplexed by the presentation of the department at the beginning of the hearing, because I think that what appears in writing is quite different from what they really intend to accomplish here. The amendment applies to people who meet the IEA standard. That's the reference to 135C:27. If you look at that, it describes the IEA standard, and it says that a person shall be eligible for IEA if he is in such mental condition as a result of mental illness to pose a likelihood of danger to himself or others. The IEA standard only applies to people who are dangerous as a result of mental illness. And so that doctor who was telling the commissioner at some point that he had somebody who was not mentally ill, and so the only way he could hold that person was with an IEA. Well, he was improperly applying that statute, and I'm quite concerned that there seems to be a misunderstanding that the IEA process is not for people who are intoxicated, not for people who are have dementia. It's for people who have mental illness. So it's frustrating to see a proposal like this that by its terms applies to people with mental illness, but we hear that the purpose is to apply it to people without mental illness. The second thing that I'm perplexed by is the statement by Dr. Ballard that it is as a result of the Jane Doe case that the system has lost its ability to medically assess someone prior to having to make a rush decision about transferring them to a DRF. Well, the statute requires that the transfer occur after 6 hours. It's not the Jane Doe case that has removed that. It's that we may be at a time where there's no current wait list, and so the statute has to be applied by its terms. But we've never legally had a regime where people were held for days awaiting someone to be determined whether or not it's a good idea to IEA them. The reason that they're held in the first place is because a medical provider signs off that they satisfy the standard, and then they're supposed to be taken by a law enforcement officer within 6 hours. So it's just, I think it's perplexing to see why it is as a result of the Jane Doe case that there's all of a sudden a need arising to do appropriate medical evaluation before we transfer somebody into the mental health system. Senator Gray, you've asked about this protective custody for intoxication idea. Protective custody for intoxication has been a feature of state police power, I think, for centuries. It's definitely a part of New Hampshire statutes. And the citation is RSA 172-B:3, which basically talks about the ability of a peace officer to take someone who is dangerous as a result of intoxication into custody and do a variety of things with them, including taking them to an emergency room. But they can also, as Ken Norton described, be held at a jail until they sober up. And so it may be that the attention of the committee should be directed at that statute rather than 135:C, I'm sorry. Because that's a chapter that deals with people with mental illness, and we are hearing today that that is not the concern of this proposal. It's not those people who really need to be in the mental health system. It's people who are intoxicated or have dementia or other conditions that have created behavior problems or dangerousness problems. And I'd be happy to work with stakeholders or the committee at converting this proposal into one that does not involve 135C. Turning to the proposal itself, I just want to quickly point out some of the problems in the area of procedure that is provided in the amendment to protect people against improper confinement. First of all, there's no judicial review provided. The standard for an IEA is a legal standard. It's not a medical standard. And due process requires that a neutral and detached magistrate review whether the standard has been met. You know, with all respect to the medical profession, we left behind a system of involuntary confinement of people on the decision of a medical provider a half century ago, and we realized that judges need to determine whether a legal standard for confinement is met, and we can't abandon that even for 7 days, as this amendment would require. I'd point out that in criminal cases, the U.S. Supreme Court has said that a judicial review of the basis for custody must occur within 48 hours, unless there's some extraordinary or emergency circumstance. We shouldn't be providing more procedural protections to people who are accused of a serious crime than for people who, as a result of illness, find themselves in an emergency department. Second, the review is only upon a person's request, and this would be by a person who may be experiencing a significant health crisis, which may interfere with their ability to understand or articulate or communicate. There's not even a requirement that the person be notified of the right to seek such review or of how to make the request. No provision for assistance of any sort, let alone the assistance of a lawyer, which is provided under the current IEA probable cause hearing standard. In many cases, the combination of a disability and the lack of information and lack of assistance would make the process really unmeaningful and make it extremely vulnerable to constitutional challenge. There's no particular qualifications required for those who are doing the review at the department level. Do they have to be mental health clinicians? Do they have to have any sort of legal training with regard to the Iea standard? Do they have to have any independence from those who may have an interest in the outcome of the decision? Those are all hallmarks of a reliable decision-making process. I think it would make a lot of sense for the scope of the review to include some consideration of whether rescission of the Iea status would be appropriate. Senate Bill 590 in 2018, a bill sponsored by Senator Bradley and co-sponsored by you, Senator Gray, resulted in a provision in 135C that allows for the opportunity to divert somebody to community services from the emergency department rather than keeping them in the pipeline for admissions to the New Hampshire hospital. It seems like if an independent third party is going to get involved in reviewing the circumstances, they ought to be taking a look at that. There's a problem with the stated purpose of the protective custody. The amendment says that the custody is for the purpose of a simple administrative activity. It's to occur until, I quote, until an involuntary admission certificate can be fully completed. That suggests that this is for the purpose of holding somebody until the paperwork can be completed. There must be something more involved here, obviously, and there is something more involved. And it ought to be stated clearly in the statute, what is the purpose of this extended custody, so that people can challenge whether or not it's an appropriate application of the statute to remove their liberty. We absolutely agree, however, that it would be helpful to take an early look at whether someone being held in an ER fits the criteria for an IEA or indeed for this other status that is being proposed. And it may make sense for a state agency expert to participate in that process. I think there are a lot of ways that they could help understand where the system could be improved, how to assist local providers, how to respond to changes in sort of the public mental health needs of our population. But it is not a substitute for the due process protections that are guaranteed by our existing statute and by the Constitution. I guess I will.
Okay, thank you, Mike.
Thank you, and I'd be happy to answer any questions.
Seeing no questions, thank you very much, Mike. All right, let's move to Steve Onan.
Good morning. Can you hear me?
Good morning, Steve. How are you?
Sure. Great. Thanks so much. Good morning, Mr. Chairman, members of the committee. My name is Steve Onan, and I'm the president of the New Hampshire Hospital Association. I appreciate the opportunity to be with you today and share some of our thoughts on this proposed legislation. We appreciate the challenges facing us in New Hampshire today. Our hospitals have been on the front lines of the ED boarding crisis for nearly a decade as we have sought to ensure that our patients are able to get the care they need when and where they need it. Our goal to ensure the health and safety of the patients we serve is very much aligned with yours. We have been and will continue to be partners in serving these patients. The state's mental health system didn't get into the position that it's in overnight, and the efforts that are being undertaken to further the state's 10-year mental health plan are designed to move us in the direction of a robust, effective mental health system that can serve patients across the full continuum of care, from outpatient care to mobile crisis to inpatient crisis stabilization to transitional housing and other supports to help people live successfully out in the community. The efforts over the past few weeks that the commissioner outlined that she has taken earlier in this hearing have been significant and have resulted in a dramatic reduction of the number of adults waiting in hospital EDs for care at New Hampshire Hospital or other designated receiving facility. But obviously more can and should be done, and as she outlined, is being done to ensure long-term solutions are implemented. While we understand the significant challenges in the current environment, whatever the good intentions, as others have said, we are concerned that the amendment under consideration today would only serve to perpetuate a system of delaying when patients are able to get the care they need. Unfortunately, we find ourselves at the end of a legislative session, and there simply hasn't been time to sit down together with stakeholders to discuss all of these important issues. I truly believe we would be better off if we could take a much more collaborative, deliberate approach to resolving these issues. And whatever we do should be part of a comprehensive plan to address the court's decision and ensure the best care for patients. We certainly pledge to continue to be part of that dialogue. Indeed, opportunities around additional education, and partnership between hospitals, community mental health centers, clinicians, New Hampshire Hospital, and others involved in the IEA process can and should be pursued to ensure that IEA certifications are appropriate, which we believe they are. The challenge, obviously, for a clinician in the emergency room managing patients, they make the decisions they make based upon the presentation of the patient in front of them, and they want to make certain that that patient gets the care that they need. We certainly think there are opportunities for greater collaboration around triage. You know, thinking about the pandemic, hospitals across the state worked hand in hand with one another, with the department, with the state, to ensure we were able to manage patients to get the care that they need. We believe, and we have talked about implementing something similar related to this patient population to try and ensure that we're able to get patients the care they need and get them to the treatment site where they can successfully get the care that they need. We think that that's truly an important opportunity and one that we should explore and move together rapidly to get to. Again, providing patients the due process is absolutely an imperative, and we certainly agree with that. But equally important, and just as important, is ensuring that patient gets the care that they need. And that's what we believe is so fundamentally important, is ensuring that patients are able to get the care they need when and where they need it. So, Mr. Chairman, thank you very much for the opportunity to share some thoughts. I'd be happy to answer any questions you or the committee might have.
All right, one question. Go ahead, and don't make it 4.
Thank you, Mr. Chair, and thank you for taking my question. You know, I have a rebellious streak, Chair, so, you know. Anyway, so my question was one that I had asked previously, sort of if you could share with the committee what the hospitals see as barriers to these hearings when folks are admitted to the hospital in the ER. What are those barriers to doing those hearings in the ER?
So when legislation was passed several years ago that called on the commissioner at the time to look at exploring options of dealing with due process for patients who are awaiting a hearing, we sat down and worked with the department. We had 4 hospitals that came to the table and said that they were willing to look at a pilot project that would provide those probable cause hearings in the emergency departments. After several months of intense discussions, all of the stakeholders came to the conclusion that it was not a viable solution to provide those probable cause hearings in the EDs for the very issues that Commissioner Shibinette and others outlined earlier, in terms of the safety and security of the patient, of the staff and others in the hospital, the physical ability to hold those hearings in the emergency department. And at the time, and we continue to believe that that is a barrier that we simply are unable to get beyond. And I would also indicate, if we are able to, as the law requires, and as the Supreme Court noted, that when an IEA certificate is certified, that patient is to move concurrently, immediately to the treatment site where they're able to get the care they need and the due process that they deserve. And that's what we believe continues to be the goal.
Great. Thank you very much, Steve. Griffin, if you could pull in Lisa Madden from Riverbend.
Hello, can you hear me?
Good morning, Lisa. How are you?
I'm very well, thank you. And thank you for giving me the opportunity to speak with you today. As you said, my name is Lisa Madden. I'm the president and CEO of Riverbend Community Mental Health Center and the vice president for behavioral health for Concord Hospital. I'm speaking in opposition of HB 565. The current definition of HEM 403 defines community mental health programs, commonly referred to as community mental health centers, as a mental health program operated by the state or city, county, or nonprofit corporation and approved pursuant to HEM 403 for the purposes of planning, establishing, and administering an array of mental health services. When RSA 135C and the relevant administrative rules in the Community Mental Health Center contracts are reviewed, you can see an intentional plan for regionally based nonprofit providers to provide a broad spectrum of services to individuals deemed eligible per the system regulations. Some of these required services are reimbursable by third party and some are not. All services require a considerable administrative documentation and reporting. Peeling off some of these services that are more likely to generate adequate payments for private for-profit entities will erode the ability of the existing community mental health centers to provide a network of care and to maintain financial integrity. Although not intended, this will result in the fragmentation of care for clients and could actually weaken the system of care in New Hampshire. As nonprofit entities, designated community mental health programs do not seek to generate profits to give back to investors or shareholders. We reinvest in the workforce and in program development to further the mission of the organization and to improve our ability to meet the clinical needs of our communities. We respectfully request that rather than peel off resources to add to the bottom line for a for-profit entity, that the focus be on adequately funding necessary community-based services to meet the needs of New Hampshire citizens living with mental illness and addiction. In fact, the recent comments by Governor Sununu and Commissioner Shibnett, when they spoke of increasing resources for CMHCs to be able to sustain the full continuum of care, most notably regarding supported housing and community-based interventions, were welcomed by all community mental health centers. This is great news for everyone. Our families, friends, neighbors, and constituents will have improved access to services, and CMHCs will be able to invest in staff and programs that can be available for the long term. CMHCs are 100% committed to being part of the solution to the mental health and addiction crisis we are facing at this time. Regarding the second part, I'd first like to speak on behalf of the providers. The providers in emergency rooms take in everywhere who are doing Iea evaluations, take this responsibility extremely seriously. There's a recognition that people are suggesting that they are taking away people's civil liberties to being able to stay in the community. So although there's times when it may seem like they are not upheld, I don't believe that there are providers that are doing this or putting people on Iea status without careful regard for their health and the health of the community. So therefore, adding a category for medical protective custody that is managed outside of the court system would not benefit hospitals or CMHC staff who provide psychiatric emergency services in hospital emergency departments. Such a change would be an end run around the recent court decision, which bars holding Iea individuals for longer than 72 hours without a hearing. The focus, again, needs to be on funding adequate community-based services. Some of these services are addressed in current proposed budget. Just a quick example would be the community mental health centers have long requested an increase in the housing rate that we receive. It's not to make money, it was to keep programs open. Riverbend is able to keep some programs open despite the loss of $1.2 million annually for the programs that they serve. Other community mental health centers were forced to close their housing programs, so they simply could not sustain them. For some non-CMHC providers have been receiving rates 80% higher than CMHC facilities for several years. The change in funding that is being proposed now will increase supported housing or residential beds in their region to support individuals who may not otherwise be able to stay in or return to the community. Mobile crisis services are expanding, and we believe that community mental health centers provide that service in a way that is intended and as part of the full continuum of care. Focusing on attracting and retaining an adequate workforce for community-based care and adequate sustained funding will absolutely result in improved access to care and therefore the reduction on boarding in the emergency department. Finding ways to extend holding individuals against their will or giving limited resources to for-profit entities will not get us where we need to go to support our constituents. Thank you very much for your time, and I will gladly answer any questions.
Okay, thank you very much, Lisa. Seeing no questions. Okay, so now the time being 11:30, I think this Zoom has to end by approximately 12, and the committee has to take action on the bill. I'm going to ask every person who has signed up to speak to limit their testimony to 1 minute. If that is possible, I'd be very appreciative. So we'll start with Carolyn Letellier.
Senator, I do not see Carolyn in the attendees list. Carolyn, if you're there, please raise your hand. We can come back to her, Senator.
All right, Virginia Nosif.
I do not see, oh, hold on. Nope, I had her. She just dropped her hand. One second.
All right, Karen Trudell.
I see Virginia Nosif on here. I can bring her in.
Okay, all right,
Okay, there we go.
Thank you.
great. Good morning.
Good morning. Can you hear me okay?
Yep.
Okay. My name is Ginny Nosif, and I live in Conway, New Hampshire. I'm here to ask you to join with me in opposition to the proposed amendment to HB 565. This past January, my 24-year-old son, who was hallucinating, waited 2.5 weeks in a windowless room in the emergency room at our local hospital, Memorial Hospital in North Conway. There were no psychiatrists, no psychiatric nurses in that hospital, and the community clinicians from Northern Human Services mostly checked in by video. He received no treatment whatsoever except food and water for 2.5 weeks. This amendment allows a hospital to hold a person in crisis for 7 days without due process or necessary treatment. Why would we do this? I'm afraid that if this amendment is approved and my son has another crisis, that our community mental health centers and a full New Hampshire hospital will take the 7 days this amendment will allow. We are so close to addressing this gaping hole in our mental health system, and this amendment has the potential to backtrack us. Science has demonstrated that early intervention in the onset of psychiatric emergencies can improve long-term prognosis and prevent structural brain damage. Each day an adult or child waits in an ER, their condition worsens and thus recovery lengthens. We need to treat all psychiatric patients in a timely, effective, and respectful manner, especially in the North Country. Our hospitals are small, very small. For all of the individuals and their families affected by mental illness in our state, I urge you to oppose this amendment. Thank you.
Thank you very much. Okay, thank you again. And now if we can move to Ms. Trudell.
Hi, thank you for taking my testimony, Commissioner Bradley, Senator Bradley, and members of the committee. I am a consumer of mental health. I strongly oppose House Bill 565 as it is written currently. I was a patient in Concord Hospital ER, as Ken mentioned, for days on end. And let me tell you, it is the most inhumane thing I've ever experienced. They don't take the time to go through the things they brought with you to go into the hospital. So you're basically given a gown and said, here you go. Well, the last time I went to Concord Hospital, I was really mentally ill to the point of getting physically sick constantly. So there was one point where I was running to the bathroom, and I left the door open a crack when I was back in there. And the nurse was like, what are you doing? And I'm like, going to the bathroom. She's like, well, you're supposed to wait for a nurse. I'm like, I couldn't wait. What do you not get about this? So she's literally yelling at me when all I would be doing is laying in vomit and feces because I wasn't well. But the other part I wanted you to understand was that when you're in the ER, no matter what type of patient you are, as far as mental health goes, you do not get any type of treatment. Like the woman before me said, you get food and water, and that is it. Excuse me. I do have a couple ideas as to fix the ER boarding. Make a suitable and safe unit at the gym and NHTI like we did for COVID.
Yes.
Adults only.
Obviously, you know, if there are bills who are requested over
Hire more people at Concord Hospital EI for the sole purpose of helping staff check in with the patient. Work on the clear mental health plan as following what is needed, especially mobile crisis unit up on the seacoast and the northern country, and expand wraparound services so there is not a revolving door back and forth to the hospital, which I did so many times. And I believe that's all I really wanted to point out. One last thing, that New Hampshire Supreme Court already made the correct decision about only being able to hold people for 72 hours. If you have any questions, I did submit written testimony that Ken Norton has mentioned. I sent him a copy, and my email and phone number is on there in case you need to reach out. That is all. Thank you for your time.
Okay, thank you very much, Ms. Trudell.
Thank you, Senator Bradley.
Can we, Griffin, go to Danielle Van Dusen?
I do see Danielle. I don't have a last name. Danielle, if that's you, if you could raise your hand. That's her.
Thank you. I'm sorry. I didn't know how to enter my name in this. So I just wanted to say I'm a licensed clinical mental health counselor in the state of New Hampshire, as well as somebody who experiences mental health issues myself. There seems to be an assumption that this legislation and a new hold process for hospitals to use will reduce suffering for individuals who don't need an IEA, but end up held under this process. And while I appreciate the consideration of people who are on this wait list and the recognition that the IEA process is one that's full of needless suffering, if not exacerbation of illness, I am deeply offended that while we are still waiting for significant reforms to come to fruition, that what has been able to be, in my mind, rushed and brought forward is this proposed law, which is a new bureaucratic method to restrict personal rights. Others have written briefs that offer meaningful alternatives, and these have already been presented today. Because New Hampshire has a shortage of appropriate places to seek care and limited treatment in the community that would help people avoid mental health crisis and hospitalization, we are here. However, there is no shortage of alternative treatments that the state could support and that insurers could be compelled to support with enough political will. My experience, including a great deal of time spent working outside of this state in the state of Massachusetts, tells me that when individuals have options, there is less need for involuntary treatment and there's less suffering across the continuum. This is where legislation should be focused, not within the hospital, not with review by DHHS for involuntary holds, not without the due process that we're given in the court system. And if any time, even minimal time, or hospital resources, even minimal resources are spent.
Senator Bradley, that's been 2 minutes.
Oh, so this is not a solution. This is not a hope. That's all I would say.
Okay. Thank you very much. Thank you. If we could now move to Gary Apfel.
Off to the side where the.
Good morning. Am I audible?
Yep.
Thank you, Chairman Bradley and members of the committee. My name is Gary Apfel. I am Jane Doe's attorney from the recent case at the New Hampshire Supreme Court, although I appear in my individual capacity. I would just like to say that we're getting lost in labels. Whether you call something an involuntary emergency admission, whether you call it medical protective custody, or whether you give it some third name, the issue is whether or not someone is being detained against her will without any opportunity to challenge that through an independent person. In my client's case, and I've described the situations under which she was held in the written testimony that I have filed with the committee, My client didn't have any opportunity to contest what was happening to her. And the allegations were ones based not upon primarily the observations of a doctor at Dartmouth-Hitchcock Medical Center, but allegations by a third party. So the situation that we have is that that we're talking about now another 7 days in order to prevent someone for that entire period of time to show that the conditions of their confinement or the justification of their confinement is inappropriate. Call it what you will, that's simply not appropriate. I'd also draw the committee's attention to the fact that RSA 172(3) for protective custody provides a 24-hour limit. If police officers and jailers are able to make a determination about whether intoxication is the reason for custody in that period of time, I simply do not understand why trained doctors need 7 days to do that. There are many other things. There's simply not time for me to address that the commissioner said, but if you want me to, I'm certainly happy to address any questions that you might have.
Thank you very much, Mr. Apfel. Thank you. Can we move to Nasa Breeson? And if I've mispronounced that name, I apologize.
Senator, I do not see Nisa in the attendees list. If she's present, she can raise her hand or press *9 if she's on the phone. Otherwise, we can move along to Representative Murray. Senator?
Yep, she would be next.
Oh, I'm going to promote her to a panelist because she's got an older version of Zoom.
Hello, thank you. I think it just bumped me over. I apologize. Can you hear me?
Yep, we're good. Thank you.
Thank you so much. I did send testimony, so I will not belabor with everything that I have written, but I do want to say that I do believe that not complying with the direction of the recent New Hampshire Supreme Court's Jane Doe ruling is not only costly to our state, but it's also extremely problematic for patients, as this amendment would potentially increase the time a person could be involuntarily held before a due process hearing would be granted to a person, or that they would be placed on an IEA. And this amendment could create citizen confusion and prolonged detention. People struggling with mental health wellness deserve expediency and dignity in all aspects of society and their lives. Moreover, on lines 26 and 27 of the amendment 2021-1888S, it states that if the Department of Health and Human Services determines the criteria are not met, medical protective custody shall end. If the Department of Health and Human Services determines that the criteria are met, medical protective custody may continue. This language sounds to me as if the executive branch department, DHHS, would bear the sole responsibility in the determination of an alternate need for holding a person and pushing off a patient's due process rights. Moreover, any person entering into an emergency department should be expediently assessed in triage. And then, if an IEA is warranted, there would be a consultation with a citizen social worker, legal counsel, or other representation in conjunction with the court of law within the judicial branch in a timely manner to determine whether or not the IEA is necessary. Pardon me. I have been hearing from my own constituents around the need for services that they are struggling to find access to care around month-long searches and waits for outpatient provider availability for pediatric and adolescent care, heavy caseloads to overworked mental health care practitioners. Patients are being dropped from care when a provider switches firms or offices, and then having to begin the search for a new provider all over again. And in rural communities, there are broadband connectivity issues that inhibit access to telehealth and mental health care services. Patients who end up in IEAs have an overall lack of understanding around their adult and child mental health care rights as individuals. I have constituents emptying life savings to send loved ones out of state and out of network to receive care they can't find here in New Hampshire.
Senator Bradley, I'm sorry, that's been 2 minutes.
Thank you. On behalf of my constituency in Amherst, New Hampshire, I thank you for your time.
Thank you. Thank you very much, Representative. Okay, Representative Nicole Klein-Knight.
Second.
Hello. Thank you, esteemed senators, for allowing me the time and opportunity to speak on behalf of Ward 4, Manchester, New Hampshire. For the record, my title is State Representative and my name is Nicole Klein-Knight. Getting assistance for mental health in the state of New Hampshire has now become a privilege that only a few can receive. If you're among the majority of us, then you are used to a system that cannot help you, and in most cases can make your suffering worse. And now we are sending a clear message as a state that we know about these issues and we do not care. In New Hampshire, people of all ages and diversities suffer from mental health illness. This is an ailment that does not discriminate. Currently, we lack the basic resources to provide our communities with help. By proposing this amendment, we further shame and misunderstand that this population, by proposing this amendment, we further the shame and misunderstanding that this population of 221,000 adults, which is roughly the size of 5 Concords, as quoted by NAMI New Hampshire, has to experience on their very own without anywhere to go except incarceration with the possibility of no due process as seen on line 26. And that is just adults because they have a law protecting them. Children have it way, way worse. We have been speaking to parents that have their child waiting in the ER sometimes longer than 3 weeks. How are they getting away with this, you ask? The answer is because there is no law saying that we can't. The fact that we know that this has been going on for the last couple of years without the kind of work and brainstorming that this issue demands, and instead propose this amendment, which seeks to cause even more damage, is just shameful. We do not get to be proud and pat ourselves on the back for 0 adults waiting. That is clear misdirection of the real crisis that is at our very doorstep. For the something so prevalent in our state, it is deeply troubling. It's disturbing that this body would aim to undermine the New Hampshire Supreme Court's ruling on this very subject not 3 weeks ago. It is disrespectful to every citizen that has struggled to get help. We are calling for quality treatment, a solution to the problems that our people are going through and the ERs in the a solution to the problem that our people are.
Senator Bradley, that's been 2 minutes. I'm sorry.
Respectfully, I've been waiting and waiting, and you did not call on elected officials to have their voices heard for our communities. I will be heard, Senator. Thank you. Even the kid governor has made his entire platform about mental health access for children, which, as we know,
Representative, if you could wrap it up, I'd appreciate it.
Waiting in the ERs.
Thank you.
This is not
Seeing no
normal.
further
Senator,
questions.
30 to 40 children in the ER is not normal behavior. And you propose this amendment is shameful.
No, this is the
Down the
department's
road.
amendment.
And you need
I'm
to be held
just a
accountable
vehicle.
for not doing the job that you were elected to do by our people to protect them and treat their illnesses. Instead, you propose an amendment to continuously lock them up without any due process. Thank you.
I would just explain this is the department's amendment. I submitted
That
it.
you
at your
proposed,
request.
Commissioner, you
Thank
are
you.
responsible.
If you
Do
could
not throw.
Move to the next witness, please. Thank you.
I have
Deborah Green.
Senator, I do have a Debbie. I'm not sure if that's Debbie Green. Yep.
Okay, can you hear me?
Yes.
Yep. Good morning.
All right. Good morning. I will be very brief. I myself do suffer from major depression. I have been hospitalized 12 times for suicidal depression. So I greatly understand what this is like. And I trust that everyone, the commissioner, as well as all of you senators, the doctors, we all have the same goal. I know that we all want to help the patients, and I appreciate that. We just need to find a way to do that. And so I'm grateful that those who first talked said that they will consider reformulating the language, because this cannot end up that people languish in a cell, what feels like a cell. And apologize if I cry, but when you suffer with mental illness, it's just like if you were a burn victim and you feel pain constantly, you can't have a breath without it. You know, people who would look at you see that pain, you know, but when you're a mental patient, you have that same thing. Every breath is severe pain. and it must be treated. It can't just be locked away for a couple weeks like that. So please continue to revamp the language so that that doesn't happen. Thank you very much.
Thank you. Thank you very much. Let's see. Next.
Very well said.
Amanda Toll.
Representative Toll.
Honorable members of the Senate, I'm Amanda Elizabeth Toll, and I represent Cheshire 16, which encompasses Keene at large. I'm here today to oppose the amendment to HB 565 that seeks to bypass the state Supreme Court ruling that requires the state to grant judicial hearings within 72 hours to people being held involuntary in emergency rooms. This amendment would allow a clinician to decide a person can be held for up to 7 days. I'm here to represent my constituents who I believe, by and large, would believe in due process and getting people the services they need as quickly as possible. Blatantly disregarding Supreme Court rulings sets bad precedent. This could lead to extra litigation against the state, which of course will cost money. This money could be better spent on actually providing support to folks in mental health crisis, addressing root causes of mental health issues. Seeking information about involuntary commitments, I reached out to a psychologist who specializes in working with BIPAC folks. The psychologist noted he's never seen an involuntary commitment that wasn't traumatizing to the person being committed. Frequently, folks being involuntarily committed have multiple marginalizing identities. This commitment can mirror the incarceration system, and we should not be addressing mental health crisis in a way that feels punitive. We should be focused not just on stabilization, which is what occurs during commitment, but on treatment, which is what comes after the initial crisis. Let's not focus on finding loopholes to circumvent the court, but rather on the root causes of the mental health crisis in New Hampshire. I will be deferring questions to the mental health experts and civil liberties advocates who are here today. Thank you for hearing my testimony.
Thank you very much, Representative. Thank you. Luis Spencer, please.
Hi, thank you, Chairman Bradley, for taking my testimony today. And thank you to the members of the committee. I just wanted to say that this bill has significant implications for people both with mental health illness and all granted staters. It's talking about a protective custody situation, which implicates our most basic civil liberties. And so I am concerned when I hear Commissioner Shibinette say that this is an issue she's been talking to providers about for the last several years. This need to separate out the difference between folks who need an IEA versus others who might need some sort of quote unquote protective custody. It raises deep concerns about the process that we're engaged in here. When you have issues of such grave import that implicate our most fundamental constitutional rights, it seems to me that to bring an amendment at the last minute that requires a suspension of the rules is not the best way to create public policy. And so for many of the reasons others have spoken to, I oppose this second part of this amendment. But I also think because of the process itself, I also oppose the amendment. And I guess I should say for the record, my name is Louise Spencer. I am a co-founder of the Kent Street Coalition, although I'm speaking today on my own behalf. And I thank you very much for taking my testimony.
Thank you very much. Ken Barnes, I believe, is next.
Senator, I do not see a Ken Barnes, but I do see a Ken Snow. So I'm going to take the chance that that's the.
All right. Okay, fine.
Ken, you should be able to unmute on your end.
Hello, can you hear me?
We can hear you.
Yep. Thank you. I'll be very brief. I'm Representative Ken Snow. I serve in Health, Human Services, and Elderly Affairs in the House. And I'm also worked in the community mental health system in New Hampshire for 48 years. Earlier in my career, I was involved in frequently going to the emergency room to evaluate clients who potentially could be involuntarily admitted. to the hospital. I signed in opposition to this bill, but I would just like to make a suggestion that if further work is done on it, the advisory opinion called for in the bill by the staff at Health and Human Services is purely advisory. It doesn't meet the due process requirement that we're expected to meet. It seems to me that one of the barriers in hospitals to do the probable cause hearing at the hospital is the ready availability of judges at any of the local hospitals to conduct those hearings. We have a hearing at Concord Hospital, and now that we've all become much more comfortable with remote access, as evidenced by this public hearing today, perhaps we could have those probable cause hearings conducted centrally at that court on the New Hampshire Hospital Department of Health and Human Services buildings remotely, and that would allow the due process to be completed within the time frame called for. Thank you for considering that, and if I can be of any assistance in working on this bill further, I'd be happy to volunteer to do so. Thank you.
Thank you very much, Representative. Thank you. Our next speaker is Cheryl Bailey.
Senator, I do not see a Cheryl Bailey in the attendees list. Cheryl, if you're there, please raise your hand or press *9 if you're on the phone. Otherwise, we can go to Representative Tim Horgan.
Okay, we'll go to Tim Horgan. And Senator Sherman is trying to rejoin.
Oh, he is?
Go ahead,
Okay.
Representative.
Okay. Oregon. Okay, good morning. Can you hear me?
Yep, good morning.
Okay, great. So I'm Representative Timothy Horgan. I represent Stratford County District 6, the towns of Durham and Madbury. So I agree 100% with everything that my House colleagues have said in support, in opposition to the bill, and also everything that the experts had said. This is just a so the new language, I think it's just a poorly thought out instrument for addressing the problem. It could easily be abused. Also, in addition to the term private entity, there's no definition whatsoever of private entity. Sounds like the commissioner, the way I read the bill, the commissioner could appoint just anybody to take custody of mentally ill individuals, and that's subject to all sorts of abuse. And also, general speaking, it's also like I'm opposed in general to the trend of private prisons too, just as a form of incarceration. But on the other hand, one thing I do like about the bill is it does eliminate an unnecessary study committee. I think those are often used as a cop-out. So I'm, even though I voted for it and even sponsored a study committee bill on a different topic, I think probably having unnecessary study committees is just a bad practice. If members of the legislature are severely committed to an issue such as charitable gaming, which is what this study committee is about, they can work on our own in the summer. And certainly we've seen with this issue, we've had many commissions and study committees and bills, and really nothing, we haven't reached a solution. Anyway, I think this amendment is not a good solution. So I'd probably urge you just to, ITL the whole bill, and we'll address both charitable gaming and mental health next year and probably every year thereafter. So thank you.
Okay, thank you very much, Representative. So
got in under 2 minutes. Good.
You did perfectly. Thank you.
Good. Thank you.
So I think Senator Sherman is back. Muted, but he's back.
I am.
Oh, there he is. So I think that has concluded the list of people that want to speak. So I'd entertain a motion to go into executive session.
So moved.
Moved by Senator Gray, seconded by Senator Whitley. All in favor, Senator Sherman?
Aye.
Senator Whitley?
Yes.
Senator Gray?
Yes.
And I vote yes. All right, so let me just make sure to clarify to all the members of the public. I was approached by the department and asked to bring this forward as an amendment to the budget. I declined to do that. I spoke with Senator Rosenwald. We agreed that we ought to have a public hearing on this bill because it is an important issue. But I will say this, while the issues identified in this are important and need a resolution, we've run out of time. And I don't see a way forward personally. But I do hope that the department convenes a working group of, you know, the people that, especially Ken Norton, Gilles Bissonnette from the ACLU, Steve Onen, Mike Skibby, and representatives, and I think it was Lisa Madden of the community mental health centers. And if I've forgotten anyone on that working group, I apologize, but I think you have the ability to weigh in with a commissioner. I think that is the best way forward at this point in time. I think all of us have supported, starting with the governor on down, significant increases in the capacity of our mental health system. That needs to continue. There is merit to the discussion about, you know, people that are maybe not necessary for involuntary commitment, and you know, a different format, but it really needs to be hammered out carefully and not done so last minute. I apologize, but I can't change the date being June 8th and our ability to bring the parties together. So that being said, I think, and I would hope that the department would, you know, convene this working group. I think some of us on the committee, there can only be 2 of us, would be willing to participate in that. So with that being said, I would entertain a motion. I think Senator Whitley has her hand up. The hand's up on your screen.
If Senator Whitley, you know, would allow, I'll make the motion to re-refer. The quickest way to get this back to the House is to take action on it and have that commission between now and December, and get that bill back right to the House in January. And a motion to re-refer would do that. So I so move.
Is there a second to that?
Apparently not.
All right.
Can I ask you a question, Mr. Chair?
Yeah, go ahead.
So we have before us a bill, the original bill that was taken off the table, and then we have an amendment. There's been no action on the amendment, correct? And the amendment is a replace all for the bill?
The amendment is a replace all, so I guess the first motion actually should probably be on the amendment.
So,
and just another question on that.
Sure, go ahead.
In the underlying bill, we re-referred originally.
No, it was on the table.
It was on the table.
So we could put the bill back on the table.
Which was my end goal, to put it back on the table regardless, but unless there was a consensus that everybody bought into, but clearly there's no consensus that anybody's bought into. And I see no way this amendment can go forward without, you know, an awful lot of collaboration amongst the interested parties, as I just outlined.
So we don't have to act on the amendment, do we? Do we have to ITL the amendment if it's been brought forward?
Well, we have to do something. So I think it'd be best if we ITL the amendment, and then when the bill comes back, we can put it on the table.
So I wasn't there for the discussion, so I'll leave it up to one of the 3 of you to make the motion to ITL.
All right, Senator Gray.
The only reason I would still suggest to re-refer it is that way the committee could work on it and have input from all 5 of the committee members, you know, sometime in the fall. Okay.
But we don't re-refer an amendment, do we?
You re-refer the bill, and the bill the amendment is still out there. Again, I have never seen in my years here a motion coming out of a committee to table, okay? It's usually some other motion like re-refer, and then if somebody wants to table that, then you table it with the pending motion of re-refer or kill or whatever, okay?
No, you're correct in that. A committee can't recommend tabling. So our options are pass, inexpedient, or re-refer.
But we need to do something with the amendment first.
I think we
right?
should do something with the amendment. Yeah.
Okay, so I'll move ITL on the amendment then.
Okay. All right,
Second.
is there a second for that?
Sure.
Senator Gray is seconded. Is there any further discussion? All right, we'll call the roll. Senator Sherman?
Yes.
Senator Whitley?
Yes.
Senator Gray?
Yes.
And I move yes. So if we want to move re-refer, because then we're back to the base bill and it can be on the table.
That's fine with me.
that. Okay.
Right. So I'll second Senator Gray's, if he's making that motion to re-refer again, or if it's still out there, I'll second it.
Yes, I'll make the motion.
All right, so Senator Gray has moved to re-refer, seconded by Senator Sherman. All in favor, Senator Sherman?
Yes.
Senator Whitley?
Yes.
Senator Gray?
Yes.
And myself, I vote yes. All right, can we quickly get a consensus of the committee on at least some of the bills that we have to recommend either concur or committee or conference? I'm still waiting to hear back on Senate Bill 45 from Senator Guida and Senator Rosenwald. I think we can, as a committee, just touch base with me on the floor, or no, actually before that, try to do it tomorrow. If Senator Guida and Rosenwald want a committee or conference, I think we should go along with that because they're the authors of the bill.
I agree.
But let's hold on that for now. I think Senator Sherman.
Bradley, who will be speaking to the bill on the floor?
We don't have anybody yet on
HB 565.
I will.
Okay, thank you.
And I'll move to table it right away. On Senate Bill 74, that's Tom's bill, and he has recommended concur. That's the advanced directive bill.
Right, that was a very careful work done with the chairman of HHS on the House side, and we involved all of his stakeholders, and we had agreement from Paula Menahan and Kate and the original collaborative. So there was one thing that came up, and I just, for the record, if there is a record, I want to make sure people understand there was a concern about a clause in that about pregnant women in one of the forms, and that clause was there in our existing statute. So that was not touched. It wasn't changed. It's not. There's no changes there. So the hope is that we will concur and move forward with this. And if somebody wanted to bring that back, they could work with the collaborative and look at it. But we did not try to change any of that had to do with existing statute, other than what you have seen, and then some minor changes on the House side.
Okay, everybody okay with concur? We don't need a formal vote, but everybody's saying yes. Okay, the next one is Senator Hennessy's Bill 97. Part 1 was deleted, but Senator Hennessy has decided that she will take Part 2 and move on because of the opposition of the House to Part 1. Everybody okay with that?
Okay.
All right.
Yep.
All right. The next one is Senator Sherman's bill on physician assistants to be able to practice at the Manchester VA. I think Senator Sherman said he was okay with concur on that. Everybody
Yeah, and that
okay
was, yep, that was a good change, made it clear, so it's good.
Senate Bill 149, I have to admit, Tom and I talked yesterday, and I have not had a chance to double back and look at parts 2, 3, and 4 that were removed from the bill. So, Tom, do you have a recommendation?
Yeah, the parts that are remaining, I looked through this, and I'm not sure. It doesn't, unless I'm missing something. When we sent it over with only 3 parts. SB 149, as amended by the Senate, had Roman 1 through 3. So I'm not sure, and the only amendment I could find was on the automated pharmacy systems, and that was brought by Bill Marsh and Gary Merchant, and it's a good amendment.
Okay, so you're recommending concur?
Yeah, if I'm looking at everything correctly, SB 149 FN as amended by the House looks fine.
Okay, all right. Everybody all right with that?
I'll need to take another look to make sure, but.
Okay, all right.
And if Jim, if you find anything that I'm missing, would you mind just letting me know? Because I can jump back to Representative Merchant and Representative Marsh and just make sure it's all good.
I will.
Okay, thanks.
Okay, the last one is my bill that I filed for the Department 162. The biggest change was dropping section 48, which is the interstate compact for child placement. I did talk with John Williams. The department is okay with where the bill is at, so I'd recommend concur on that.
So I think we need to think about that one a little more. I mean, that interstate, I don't know why they dropped that interstate compact. That was just to sort of align with the rest of the country. So that seems weird because it's about, it's a significant issue because we're talking about kids. The second part, adding it, we have to look at what that does to the new processes we created under SB 14, which is that kiddos are supposed to get an assessment before they're placed out of home. So I'm a little concerned about that. I think we need to look at that one closer.
Right. Can you then reach out to the department? And I didn't talk to John, I just exchanged emails. So
okay,
we'll put a question mark on that one, and we'll put a question mark on 45, but at least we're heading in the right direction.
Okay.
Okay. Is there a recommendation to come out of exec session? Moved by Senator Sherman, seconded by Senator Gray. Senator Sherman?
Yes, sorry.
Senator Gray?
Yes.
Senator Whitley?
Yes.
Myself, yes. Okay, motion to adjourn. Senator Gray, seconded by Senator Sherman. Senator Gray?
Yes.
Senator Whitley?
Yes.
Senator Sherman?
Yes.
And I vote yes too. Okay, thank you very much.
Thank you.